Hello and welcome. We're discussing 10 years of womb transplants. What have we learned? What does the future hold? The hashtag is womb transplant. This discussion has been made possible thanks to the generous support of Merck and the Create Health Foundation. I'm Sarah Norcross, Director of PET, and I'll be chairing the discussion. The first human womb transplant represents really a monumental achievement in reproductive medicine. And reproductive medicine is a field which is continuously evolving to address fertility challenges. And when that first baby was successfully carried in a transplanted womb or uterus, that was an achievement of just another order of magnitude completely. It was just amazing. And our discussion marks the fact that it is just over 10 years since that first live birth following a womb transplant. And this work was pioneered in Sweden, and we're honoured to have the leader of the medical team that was responsible for that achievement, Professor Mats Brännström, on the panel tonight. And but the first womb transplant that was carried out in the UK happened only last year. And we're very excited to hear from two of the team that performed that surgery and have done so much more to make womb transplant available in the UK. So we'll be joined this evening by Professor Richard Smith and Dr. Isabel Quiroga. And when we're thinking about these procedures, we need to bear in mind patients, the women for whom womb transplantation may be the preferred reproductive choice. And these women may have no uterus, for example, if they have MRKH and they have an underdeveloped uterus, or in fact, no uterus at all. Or they may have had a hysterectomy as part of cancer treatment. So we're really fortunate to hear from a woman about this and her perspective from a very personal point of view, and that's Eleanor Findlater. Now, some of you may be thinking, hang on a minute, what about consent, ethics, the selection of the potential recipients, and how would actually we decide who should be able to donate their uteruses? And these issues can be far from straightforward. But tonight we're joined by Natasha Hammond-Browning, who's been thinking about these issues and also writing about them in BioNews. And I look back since 2015, Natasha, it's quite some time. And so we're delighted to have her taking part tonight in the discussion too. It gives me great pleasure to introduce our first speaker this evening, Professor Mats Brännström. He is the pioneer, as I said, of uterus transplantation and leader of the team responsible for the first live birth following the procedure. He's a professor of obstetrics and gynecology at the University of Gothenburg and a senior consultant in gynecology and reproductive medicine at the Sahlgrenska University Hospital. And he is editor of a book entitled Uterus Transplantation.
So I will give a brief overview of the history of uterus transplantation, and then my colleagues will join in. So my story of uterus transplantation actually started in 1998 when I was in Australia. When I was in Australia, and I met a patient who wanted a uterus transplantation. Before that, I was doing research on ovarian physiology. And I was training in gynecology surgery, and Angela was undergoing a surgery for cervical cancer stage 1B with a radical hysterectomy. And she suggested to me, why can't you do a uterus transplantation later? My mother could be the donor. And I was amazed. I had never thought about the concept before, and I thought it was impossible. But after some more thoughts, I said we should start a research project on this, and that was 1999. And of course, Angela then belongs to this group of absolute uterine factor infertile women. She has no uterus because of a malignancy of cervical cancer, but you can also have other reasons for hysterectomy, or you can be born without uterus, as in Rokitansky syndrome. I have a non-functioning uterus because of different causes. I just want to point out the Rokitansky because these are the Mullerian agenesis, born without a uterus, and that's the most common group for uterus transplantation so far. We calculate there is 1 in 500 women with this condition, and of course you have other options for motherhood, adoption or gestational surrogacy, or you can accept your infertility. So in Sweden, with 10 million people, that would be about 2,000 women between 20 and 40 years of age. So we started then doing research on this, and that was already in 1999. And I think Richard's group, together with the American group of Giuseppe Del Priore, started about the same time, also doing research. And we started with mouse, rat. I think you started with rabbits and rats, and then went out to bigger animals and then baboons. And this is a translation research project to look at all the aspects of uterus transplantation and optimize the procedure. And then we did the first clinical trial in 2012 and first live birth 2014. And the clinical flow of uterus transplantation is that you would do evaluation and screening of a recipient, and in our case we have used live donors, and that would take some months, and that is psychology, imaging, laboratory test, medical test. They will be evaluated by a committee, and if they are okay, then they would do IVF to cryopreserve embryos. The uterus transplantation will be done. We will wait for some months, up to a year, and try to get pregnant by embryo transfers. And then you would have those embryos stored in the IVF procedure before. A pregnancy would end by cesarean section because they have a vaginal anastomosis, and then you could go for 1 or 2 or 3 pregnancies, and then you would do hysterectomy. Of course, the patient would need immunosuppression during this time. If they're a deceased donor, multi-organ donor, there would be a fast screening within 24 hours of the deceased donor, and you would do uterus transplantation. So we were not the first to do this because this was actually done already in the year 2000 in Saudi Arabia. We did not know about it until it was published year 2002. And it was a live donor case. They had to remove a necrotic uterus after 3 months. And the cause is unknown, but I think one cause is that I had done very little research and optimization in animal models. So we did the first clinical trial after this case and a deceased donor case in Turkey in 2011, and it was in September 2012, and we got ethical remission and everything. We did a case series, and the first patient we had was actually a cervical cancer patient, just like the patient in Australia who gave me the ID. Now she has 2 children. They are much older today, and that was successful. So we did 9 live donor transplantations. 8 of the recipients were MRKH or Rokitansky, and 1 with a cervical cancer. They were all young and healthy, of course. They were asked to bring their own donors, which would be relatives or long-term family friends. We would say that a mother or mother sisters would be ideal, but in some case the mother was hysterectomized or had comorbidities, and they would go for other donors. We could also include postmenopausal donors. And the surgery was by open surgery, laparotomy. We thought it would take 3 to 4 hours, but it actually took us 8 to 11 hours. That is the donor in the live donor. And the difficulties is actually in this area here where you have to preserve all the vessels, but you also have to preserve the ureters from the kidney to the bladder. We only transplant the uterus, not the oviducts or the ovaries. Recipient, we did open surgery, laparotomy surgery, coupling the vessels end to side to the externally like vessels as shown here, just as you would do a kidney but on both sides, and then also anastomosing the vagina. It takes 3 to 5 hours, and it's a lot more simple surgery than the live donor hysterectomy. And then we presented the first birth a little more than 10 years ago in a paper in Lancet, and this is this little guy Vincent, who was the first born after uterus transplantation in the world. Today is 10 years and is a very healthy child. So out of these 9 procedures in the trial of 2012 to 2030, we totally got 9 children and all healthy and and also normal weight for the gestational age. We had some precautions. We had 3 cases of preeclampsia, which may be related that this patient had single kidneys. So I just want to emphasize that, as I said, the initial case was done in Saudi Arabia in 2000, and then we had all the development in the human here. But importantly, that came after we had done all the research, we and other groups, in animal species and in vitro in the humans. So this is an example of a classical translational product which is done by optimizing the procedure in animals and then bring it in successfully into the human. So the global spread of uterus transplantation today is more than 135 procedures, and the stars are where it has been done. We know that quite well. You see that most are done in Europe and in the United States, but we also have in South America and in Asia, Australia, not in Africa yet. We have 17 babies in Sweden. In USA, I think they have about 25 or 30, and these are the other countries with babies so far. But of course, we have many ongoing pregnancies. I just want to say that we now know that there are increased obstetrical complications. There is increased rate of preterm birth and respiratory distress syndrome, and also in some pregnancy complications. We think this is related to that we have actually delivered a lot of the babies electively too early. So today, and this is important, I think we have to talk about the surgical success. That is, if you get a good blood flow and menstruation, is more than 90%. And if you have a surgically successful transplantation, you have a 90%, more than 90% chance of live birth. And this is by an experienced, adequately trained teams. And this is a very effective, but of course very complex infertility treatment today. So how should we monitor this in the future? Well, there is an international registry within the International Society of Uterus Transplantation where we prospectively put in data on characteristic surgeries and the course after surgeries with live birth. And of course, both the UK and the Swedish team are members of that. And we also have mutual discussions of starting an international child registry also. Because what will happen now is that in the beginning we could publish every case report or case series. In the future we cannot do that because the novelty of of this procedure is not as big as before. But this will be our research tools to optimize the procedure in the future. And then I want to emphasize also that this is a teamwork. It's within the local surgical team, but it's also the team around the local surgical team, and it's also, I would say, a global team experience because we actually collaborate a lot to help each other.
Now, our next speaker this evening is Professor J. Richard Smith, and Richard is joint leader of the surgical team responsible for the first womb transplant in the UK, and he is joint leader of the UK research team at Womb Transplant UK. He is Professor of Practice at Imperial College London, and he's a consultant gynecological surgeon at Hammersmith and Queen Charlotte's Hospitals, and he is co-author of the book Women's Cancers: Pathways to Living.
In the next 20 minutes, which is 10 minutes for me and 10 minutes with Isabel, we're going to tell you basically a 25-year story for me and a 10-year story for Isabel. And it's really how Isabel's a pancreatic and kidney transplant surgeon. I'm a gynecological cancer surgeon, and how we've actually evolved with our team into a bunch of uterine transplant surgeons and physicians. Have I any conflicts of interest? I'm the chairman of Womb Transplant UK, and Womb Transplant UK is the charity which is funding the current UK effort. And I'm a founding member of the International Society of Uterine Transplantation, which, of course, Mats set up many years ago to great effect. And he's already mentioned wonderful talk, Mats, with the registries, etc. So our whole theme along the way has been collaboration, collaboration, collaboration. And that slide shows you the enormous numbers of groups that we have directly collaborated with. This is Imperial College and Oxford University collaboration, but there's Lister Fertility, there's NHS Blood and Transplant, the Human Tissue Authority, then Lancaster, Cardiff, speaker later, University of Bristol, Royal Veterinary College, and we did our animal work at the RVC and also in Valencia, Universitat Politecnica de Valencia. And we've been doing tissue engineering stuff with the Stevens Group. I think this is so important, that what this project across the world is about is compassion. Compassion, compassion, compassion. We are about the relief of suffering for women with absolute uterine factor infertility. And that's the end goal, is to allow, it's not to transplant uterus, it's to allow women to have babies. And these women suffer very, very much from absolute uterine factor infertility. Matt's made a wonderful comment earlier about collaboration, and one of the things which I know Isabel and I have discovered early on is that I'm a cancer surgeon, and so my role has always been to remove organs with a 1 centimetre margin of normal tissue, and they go into a histopathology pot and off to the laboratory. And I take great pride in sealing multiple vessels to cause minimal bleeding. If you're in transplant surgery, the organ comes out to go into somebody else. There's no 1 centimetre margin, and we don't want sealed vessels. We want open vessels that can be anastomosed. Terribly important. So, very brief background: 100 women trying for a baby. 6 months out, half of them are pregnant. 12 months out, 80 pregnant. That's when they're defined as infertile. But half of those women will actually be pregnant at 24 months out. A third it's the man, a third it's the woman, a third it's a bit of both. And amongst the women, we've got ovarian, tubal, and uterine accounts for 10%. So the problem, how big is the problem? Well, it's interesting because the 50,000 women estimate, and I noticed, Matt, that you actually defined an age. This was across all ages in our 70 million population. There's 100 to 200 women going down the route of surrogacy per year, and we know we've got over 5,000 women with MRKH who have been born without a uterus, without a cervix, usually with normal fallopian tubes, ovaries, and quite often perhaps a slightly smaller or narrower vagina. There's hysterectomy related to bleeding, hysterectomy related to cancer, and then there are benign conditions such as Asherman's, fibroids, adenomyosis. So what are the options if you're a woman with absolute uterine factor infertility? Well, there's surrogacy, good outcome, low physical risk. There's adoption, low physical risk and opportunity to provide a stable home for a disadvantaged child. And there's a uterine transplant. You get to carry your own baby. There's actually no legal issues. And in many ways, many ethicists regard it as superior to surrogacy. That's debatable. And it's the only way you can actually gestate if you're in this position. The downsides, surrogacy, you cannot do it if you are Muslim or Orthodox Jewish. It's country dependent, state dependent in America, and there are some legal and emotional issues. Adoption's lengthy, difficult to do. Uterine transplant, you've got a big surgery to implant the graft. You've then got immunosuppressive therapy over the time the graft's in, and then you've got to have another operation to take it out, and you're going to have a caesarean section or two in the middle of this. So our eligibility criteria are relatively tight at the moment because it's a research project. You've got to have absolute uterine factor infertility. You've got to have embryos already created by IVF from your own eggs before you can have a transplant. You need to be between 24 and 42 at the years of age. No intercurrent medical conditions. And if you've had cancer, it depends which one, but if it's a gynecological one, you've got to be 5 years in remission, and you must not have a high BMI. Now, I just want to stop at that point and point something out, which is that if you are a patient having a heart, lung, kidney, liver transplant, you are sick, and you've been used to being a patient. Our patients are the opposite. They're all very healthy. They have to be to get in the programme. So I know Mats alluded to this earlier, and we were involved in animal-based research from the late 90s. We started in pigs, we moved to rabbits, and then we moved to sheep. And thereafter, we went down the route of surveying patients, the public, and healthcare providers as to how much approval there was for the prospects of uterine transplant. 2015, we got human ethics approval, and a big thank you to Mats, because Mats and team gave us a lot of help with that stuff in 2014. 2019, we'd taken so long to get to the next phase, we had to reapply. 2020, we were good to go. COVID arrived, and we were shut down for another basically 2.5 years. And then we finally got going 2022, 2023. So the current status worldwide is over 100 performed, 2/3 living, 1/3 deceased, and probably actually 60 plus births, I think, is the current stat. Majority of live births are so far in living donors, and the retrieval times 10 to 13 hours, or in fact maybe 8 to 11 hours, looking at your slide, Mats. And then new technique, which is slightly different surgically, Isabel will go into that, which is slightly shorter at 6 to 8 hours. This slide sums it all up for us. 2015, we got ethics, as Ben Jones, Isabel, myself. We didn't clock what we had to do, which was get every group on board, rightly so. Specialist nurses, organ donation, ITU consultants, British Transplant Society, Royal College of Obstetricians, Human Tissue Authority, NHSBT, and the National Advisory Group on Transplant. 2019, we'd convinced everybody, but we still don't have sign-off. Prof. Ploig, Isabel's colleague in Oxford, I believe, pushed that over the line for us. 2020, we went live, and of course, we had the delay. What has kept us going is seeing the suffering of our potential patients who are in our clinics, my clinic down at Charing Cross, Isabel's clinics. So our patient pathway, recruitment, medical psychological assessment, IVF, entry onto the list, and then, of course, immunosuppressive therapy. You've got 6 months of observation before an embryo transfer, and then a C-section, and you're allowed to have 1 or 2 babies. It's just showing how we've kind of made this happen. Isabel and Andrea in Oxford, the Baroness Cox, Nick Mom, and Nadine Caneva are patrons of the charity, who have given us a lot of political influence and funding, but Nick and Nadine on the funding side. And then our public relations has been a huge deal with Neil Huban, John Harrison, Laurent Chaminade. So 2022, we were called and did a deceased donor explant, and we thought we got a well-retrieved organ, which we did, but unfortunately there was atherosclerosis on one side. Everything was blocked and we couldn't proceed. February 23, we did a living donor explant and implant, i.e. transplant. Our research, and Isabel's going to talk to you about that in her talk, our research project is in situ, 10 deceased human transplants with assessment of operative technique, successive IVF, study of pregnancy. That slide's rather repetitive. It's between Imperial and Oxford. And we got ethics originally. Everything we've done is ethics approved, including all of our previous animal-based work. We're involved in concurrent research with Stephen's Group, Tissue Engineering, Warm Perfusion, Organox, Surgical Communication, Bristol, Law and Ethics, Lancaster and Cardiff, and endometrial transplantation, Valencia. And vitrification we're looking at. Our next project is 5 living donor human transplants, the same criteria for the previous. And in February 23, first uterus transplant case in the UK, which Isabel will describe in much more detail. A lot of publicity when we published this stuff last summer. I put this slide up principally to show the size of the team. Matt's rightly said, this is a huge team effort. And there were actually 30 people at the huddle that morning in a stupendous effort, which lasted that day and half the following night, in fact. That's the core surgical team there. Post-op, very anxiety creating, because we know that the failure rate is there in those first few weeks and is appreciable. And of course, the anxiety continues because it continues until babies are born. The follow-up is intensive between Oxford and London. It's a big effort for these women, that is for certain. And we've had a lot of big media issues. I do like to finish with this quote: "Success is not final, failure is not fatal. It's the courage to continue that counts." And I am very blessed to have had a wonderful team, Isabel and I, around us. And Isabel is a brave and courageous surgeon, and it was me great pleasure to hand over to her.
So, as Richard just said, we're going to hand over now to his colleague, Dr. Isabel Quiroga. And Isabel is the joint leader of the surgical team, as Richard has been saying, and joint leader of the research team at Womb Transplant UK. She's a consultant transplant and endocrine surgeon and clinical lead for organ retrieval at the Oxford Transplant Centre. And she's published research and commentary on women's suitability for womb transplant, and also work about public attitudes towards that procedure and the history of this field.
We've been doing transplants for many, many, many years now, 70 years since the first successful kidney transplant. And it was until the 60s in which a flurry of other types of transplants for life-saving organs such as the liver, the heart, the pancreas and the lungs. And then there's a big gap between those really important organs until we have the first transplant of hand, which is a life enhancing. And then it's in 2005 when we do a face transplant, which is now probably life transforming. It does transform lives. And then Mats came in 2014 and was the first to successfully transplant an organ that is also, of course, life transforming, but also life creating. And it's been 10 years already, and there's only about 135 transplants done in the world. And that, with any transplant, it does take time. It takes 10, 15 years for the procedure to develop, for others to take up the procedure, but also to develop the techniques and to find out how we manage these patients. And we do about 170,000 transplants across the world. So when you're talking about 135 over 10 years, you can see how at the very early stages we are on this journey of uterus transplantation. And if I just spend a few seconds talking about my history, my story, I was first approached to just act as an advisor to Richard and his team on how to become involved with the disease part of this project. And initially I wasn't that taken by the whole, my ignorance of course, by the whole uterus transplant field. And it wasn't until months later I met the first patient, the very first patient that would benefit from this, that I understood the need for this procedure, and my life and my attitude to this changed completely. And now we have a true partnership between Oxford and Imperial, as Richard was describing well. And yes, we did through 8 years of multiple approvals going through different committees, but it's important. The Human Tissue Authority is the body that regulates transplantation. NHS Blood and Transplant are very involved in the donation process and transplantation. And it's important that any uterus transplant in the disease field does not impact negatively on life-saving organs. And of course, at my institution, you can understand that loads of people wanted to have a say on it. And even NHS England give us the go-ahead, especially after the pandemic. And why all this? As you all know, this is a non-life-saving procedure, life-creating, but these are women that are young and healthy, and we are going to make them sick, and they need to understand the consent process is paramount, because there are loads of potential risks involved: risk for surgery, risk of the immunosuppression, which by having immunosuppression, you increase the risk of developing cancer or infections and complications of the medication itself, maybe renal dysfunction or even diabetes, hypertension, etc. So the psychological support and the team effort is monumental. And when we came to the very first transplant, we had very clear in our minds that selection of the right patient was paramount, but the team, selecting that team and the team preparation was of great importance. And our first patient was a live donor transplant. We have the donor who had completed her family, was healthy and very committed to help her younger sister to become a mother. She had MIKH, and it had been her long desired wish to have a family. She had a very supportive husband and supportive family, which was super important. And as we were saying, the patient pathways as it's been described before, but I just wanted to point out that in the UK, all living donor transplants had to be seen by an independent assessor, employed and regulated by the Human Tissue Authority. And as this is a very new transplant, it had to be discussed, it had to be also approved by the Human Tissue Authority before we could go ahead, and of course in our local multidisciplinary team. With regards to the team selection, I knew I needed to have the best team available to me. And my colleagues, my surgical colleagues, Natasha and Anne, work with me almost every day. And the trust that we've developed is excellent. The same with the anaesthetists. These are Peter, Andres, and Richard. They are the ones that anaesthetize all our transplant patients. And the scrap team, the nursing team, is paramount. And how do we prepare? A week ago, I was talking to students, and the one question, it was like, how do you prepare for that? How do you manage the pressure? Well, we did what we all do when we're learning. We went to loads of conference, we read a lot. We met with loads of other surgeons, Mats, his team, loads of other surgeons across the world. We visited Dallas that had a quite active program like Sweden. And we saw we saw a transplant being done, and we also learned from others' mistakes. As we say, we wrote and rewrote and wrote again protocols, and we had meetings with the wider team, like rehearsing that operation, all the steps. But it comes to a point that you can't prepare anymore. You just have to you have to draw from your experience over the years. And we finally did the first operation in February of last year. We did it on a Sunday. We needed to minimize the impact to our NHS patients. No cancer patient could accept that his operation was cancelled because we were doing a uterus transplant. All the medical staff and most of the support staff did this pro bono. We had over 30 people, and loads of other colleagues from other specialties and management came to WISH as well. And you can see, as Richard has shown that picture, we were all full of excitement, except myself and my anaesthetist. We were a little bit apprehensive there. The transplant, the donor hysterectomy is mainly led by Richard from the gynecology operation. The transplant is mainly by myself and my colleagues. It's more about doing this small vessels. And yes, the operation was much more challenging than we were expecting. I'll always remember that Mats, Nick, one of your main transplant surgeon, telling this is just like a kidney transplant, but ×2. I have to say, I do a lot of kidney transplants, living donor kidney transplants, and these vessels look nothing like kidney vessels. But nevertheless, at the end, we had a fantastic success. The transplant team, the surgical team, and then all my nursing team, which were phenomenal. Both patients did very well. They went home as expected. And how we are managing them, as Richard is saying, we manage it just first to see if there's good blood flow with scans. Then we need to monitor for rejection with biopsies. And importantly, the function is only when they have the first period. And when she had her very first period 2 weeks after the transplant, it was a truly joyous moment for all of us. But of course, the measure of success is whenever we have our first baby. My experience, just to finish it off, Yes, as Richard was saying, we were front page of all the British media, and it was quite a shocking moment to see yourself at the BBC News. But importantly for me, it's been great operating with Richard and with the extended team. It's been amazing, and I think we now have a truly sustainable program. But importantly, when we announced our first transplant, we have given reassurance to all these women that are already in the program. More patients have come forward with wanting a transplant, but incredible hundreds, and I'm literally hundreds of women have contacted us wishing to become donors, wishing to give that opportunity to others. And as the experience grows, and now truly convinced that a uterus transplant is the best option for some women, not all, of course. And I would just like to highlight the fact that women make very difficult choices every day. They risk their health, their livelihoods in the pursuit of motherhood. And with this operation, we have given, yes, the opportunity to one couple of parenthood. We're giving hope to many, but importantly, we have increased the choices for thousands of women and girls in the UK. And this is not comes as a surprise to you, but the number of people that are very, very closely related to this project is huge. For us, the important thank you as well is to Womb Transplant UK that are supporting us.
Our next speaker is Eleanor Findlater, and Eleanor is going to give us the patient perspective. Eleanor went through a hysterectomy. She is an advisor to Womb Transplant UK, and I won't say any more about her because I will let her tell her personal story.
Hello, everyone. Thank you very much for inviting me to join this online discussion. It's a subject I feel very strongly about, so I'm honoured to have been asked. Everything I speak about is from the heart and first-hand experience. So I still find myself getting very emotional about it, so apologies that I'm reading from my notes. 20 years ago, almost to the day, I had a hysterectomy, which was performed by Professor Richard Smith at Princess Charlotte in Hammersmith, and I was 32 years old. I'm lucky enough to come from a close family, and when I met and married my husband, Andy, like many newlyweds, I couldn't wait for us to start our own family together. As the months went by and nothing happened, we became increasingly concerned and knew something was wrong. I was referred to Professor Richard Smith and had a series of tests. When Richard sat me down, nothing could have prepared me for the diagnosis. I had adenosarcoma of the uterus, which is uterine cancer, requiring hysterectomy. I was 32 years old, and it was 6 months after my honeymoon, and I was being told that I'd never be able to carry my own children. So I didn't even take in that I potentially had a life-threatening disease. The shock and devastation of being childless was so great that it eclipsed everything else. I wanted to leave the hospital in the hope that it would somehow eliminate what I was hearing. I had the audacity to ask Richard what his qualifications were, in the hope that I could reverse what he was telling me. As the news started to sink in, I even apologized profusely to my new husband sitting next to me and told him that if I could not have our own child, he should walk away. Richard started explaining to me in his calm and reassuring manner that there were various options. He said that he was working towards the first womb transplant, and my immediate and overwhelming response was that I wanted one. And this was 20 years ago. So if I could have fast forwarded the medical advancement to be able to receive a womb transplant, I would have done so in a shot. Instead, we had to look at other options, such as adoption and surrogacy. After further research, I discovered that our chances of adoption were minimal, given my medical situation. And despite the fact that I was clear of cancer post-hysterectomy, the adoption process still required another 5 years of being in remission before we could adopt. After the hysterectomy, I was on a ticking time clock to harvest the eggs in order to create embryos before the ovaries failed. We investigated surrogacy, which led me to the surrogacy agency COTS that pairs surrogate mothers with potential parents. We were unusually lucky. Within 3 weeks, we were matched with a surrogate. And in 2024, the average time to get on the waiting list is 18 months. And after that, you're incredibly lucky to even get matched within another 18 months. Once matched, we met with our surrogate and her family, and we hoped that she would like us and agree to carry a child for us. The next hurdle was months of IVF and waiting to find out if our surrogate was pregnant. My ovaries were left intact, so we were trying to implant embryos in the hope that they would take. Trying to get another woman pregnant with your child is hugely challenging, emotional, and unpredictable roller coaster for all concerned. And after a long, drawn-out, fraught process, our surrogate eventually gave birth to our 2 miracle boys, and for this, I'm eternally grateful. However, a day does not go by that I don't see a pregnant woman and still have a pang to experience pregnancy. It's 18 years since I witnessed another woman giving birth to our firstborn son, and the feeling is still as strong today as when I was first dealt the blow. There can also be a huge ethical issue with surrogacy, and while we're fortunate in our relationship with our surrogate and our family, for many there can be huge problems and issues surrounding a woman carrying another woman's child. So when Richard asked me to join the charity board for Womb Transplant UK, I jumped at the chance, and I knew I just had to support such an important cause, knowing that if I had had the opportunity to have a womb transplant 20 years ago, I would have had one. For many people, having children is a basic right. They assume that it will happen naturally and easily, and fortunately, for many of the population, it often does. However, there are also people like me for whom life takes a more unexpected turn. It felt like a hugely cruel blow to be given a hysterectomy, just as my friends and contemporaries were all excitedly planning pregnancies and giving birth for the first time. So unless you've been in that situation, I think it's impossible to understand the pain of being denied such a fundamental human experience. I also want to add how fortunate we are to live in a world today where, through the advancement of science and medicine, driven by the sheer dedication of brilliant and pioneering doctors, such as Professor Smith and Isabel Quiroga, many future mothers will have the opportunity to carry their own baby when once they might not have been able to. It's 20 years too late for me. However, it's incredibly exciting to witness how many young women's lives could change from the opportunity to have this womb transplant.
Our final speaker for you this evening is Dr. Natasha Hammond-Browning. Natasha is a senior lecturer in law and the study abroad director for law at Cardiff University. She is co-editor of the book International Legal and Ethical Perspectives on Uterus Transplantation.
Well, thank you very much to Sarah and to Pet for the invitation to speak to you all this evening. As Sarah said, I'm actually a senior lecturer in law at Cardiff University. So my perspective is very much as an observer of the medicine that's been going on. And my thanks to the medics who are here, who are talking about their experiences, and thanks to Eleanor as well for your perspective as well. It's really important to have that. As Sarah said, I am a co-editor of this book that you can see on the screen, International Legal and Ethical Perspectives on Uterus Transplantation. And this is the first book that brings together scholars from across the globe who discuss the law and ethics around uterus transplantation. And I've also written a couple of chapters within the book. What I think has become apparent for me is that whilst I was writing for this book and editing the chapters that are within it, it became apparent to me that the issues that were raised 10 years ago following the announcement of the first birth after a uterus transplant are issues that are still being discussed today, and so I think they'll continue to be debated in the future. Now, what I'm going to do is to briefly outline some of the legal and ethical issues that I think are most pertinent, but please forgive me for any that I miss, because obviously we've got a short time to speak to you tonight. Excuse me. Okay, so I'm going to stick to just one slide. I've put all of the issues that I think are important on this slide, and I'm going to pick out some of the ones that I think are important for tonight. Now, what I want to point out first of all is that Sarah's asked me to talk about ethics. I am a lawyer by background, so I've kind of looking at both, but that there is a lot of overlap between the legal and the ethical issues, as well as amongst the sort of the groups that I've put here. The other thing I want to note is that the law and the ethics are important, but it will vary upon the country that the clinicians are working within, although there are some issues that will cross those legal boundaries. So first of all, looking at regulation and the oversight. So my background is law. I'm an academic and in law. So I am interested in who is regulating uterus transplantation and how it's being regulated. So, for example, within the United Kingdom, both the Human Tissue Authority and the Human Fertilisation and Embryology Authority are involved due to the fact that these two bodies very carefully regulate and oversee organ donation and transplantation and assisted reproduction. Whereas other countries might not have such bodies and instead rely on maybe ethical guidelines or professional regulation. So I'm interested in who is overseeing uterus transplantation. Now, that is from approval for the clinical trials through to uterus transplantation as a treatment. And potential recipients may also want to know who is providing that oversight. Now, for the last 10 years, uterus transplantation globally has been overseen and regulated through protocols, committees, statutory law, guidelines, and so on. But all of that oversight has been concerned with uterus transplantation as a clinical trial. Now, in some countries, uterus transplants are moving towards clinical treatment, and so that oversight might change. So I think that's important to bear in mind. I've also mentioned about this right to gestate on my slide here. Now, I just wanted to note that there is debate in the community around whether there is a right to gestate, and if so, who has that right to gestate. Now, from a legal perspective, that's an important issue, as if we say that there is a right to gestate, then that may result in a corresponding right to access uterus transplantation. And that may then also impact whether the state has an obligation to provide access and support. Now, the answer to this question will depend upon your personal values, but will also depend upon the law, ethics, societal and religious makeup of a country. So the answer in one country may be different to another. I'm just going to mention, I think because the clinicians have raised this as well, is around the selection criteria that has been used for the clinical trials involving uterus transplants. Now, I think that some of the selection criteria that have been used might require clarification or alteration as womb transplants move towards clinical treatment. And that's because some of the selection criteria that are used might not be, I'm not going to say fully legally compliant to imply that anything has been done illegally. That is not the situation. But some of the criteria might be there because of the fact that it's a clinical trial rather than treatment, or that it has an ethical value attached to it, which goes beyond the medical justification for inclusion in that criteria. Now, I'll give you an example. Richard and Isabel both highlighted the fact that the UK team requires recipients to be able to produce their own eggs in order to create embryos. Now, within the UK, we allow the use of donated gametes in assisted reproduction. So it's just an example where teams might need to justify their departure from those legally permitted norms or remove the restrictions on accessing and using donated gametes. The UK team's not the only team to do that, but just highlighting that as we have two of the clinicians here. The allocation of uterus transplants as well is something that has had a lot of ethical debate around how we decide who receives a uterus transplant. So once you've been selected for treatment, how do we decide whether you receive a uterus? Now, When it's directed donation, so say from a mother to daughter, that is less problematic. But if we're using, for example, deceased donors, who do we decide receives that uterus? Now, it could be a criteria around the age, how long you've been on a waiting list. It could be a lottery. But these are all ethical issues that will continue to be debated as we move towards treatment, this being an accepted treatment in the future. And as we move to that being an accepted treatment, womb transplants, we'll also need to consider who's funding this. At the moment, it is a charity in the UK, the Womb Transplant UK charity, that are funding it. But there are questions around whether private individuals, the state, or possibly insurance, depending upon the country that you're in, as to who funds this. It is an expensive process that has to be undergone, and also IVF is expensive as well. Equity of access is important, and the funding and allocation of limited resources will need to be weighed carefully as we move forward with this treatment. Now, as Eleanor highlighted, like, she would have loved to have had this opportunity to experience gestation, and it is something that obviously is important to many women, which is why obviously this is seen as being a very valuable process. And in considering whether someone has a right to gestate, it's thinking about whether there is a right, who has that right, but also we need to consider that in light of reproductive autonomy. So by that, I mean that people have the right to choose, to control, and decide about reproduction. Now, uterus transplantation is obviously something that will give people another option around reproduction. But it should be noted that within the ethical literature, there has been a lot of discussion around whether uterus transplantation is something that should be pursued, because it actually might reinforce pronatalist values. So this is the idea that women are seen as having value through their reproductive potential, and that actually we're reinforcing the expectation that women should be gestating and reproducing. So there is debate around whether we should be giving greater preference to adoption, to surrogacy, to supporting children who already exist and who need care. So I just wanted to highlight that there is that debate there. And there's also a discussion around the risks that are being undertaken by recipients in order to gestate a child. As Richard pointed out, the women who are participating in the trial with Womb Transplant UK are essentially healthy. These are women who don't have a lot of contact with healthcare professionals on a regular basis, but that are actually then undergoing a process that will require extensive cooperation and involvement with healthcare professionals. So the reproductive autonomy is something that will continue to be debated. It's something that is important to be discussed in light of potential recipients giving informed consent to this process that does involve substantial risk. Of course, the other side of the argument is that this is giving women with absolute uterine factor infertility greater autonomy and choice, that it's supporting reproductive autonomy, that they have got an option to gestate. And I think in my last couple of minutes that I've got, Sarah, I'm just going to mention what I've put under this heading as a donation framework, a couple of points that I just want to raise here. As we've been hearing, uterus transplantation can be performed either with a living donor or a deceased donor, and there is a discussion within the medical arena around who might be the most appropriate to use, and obviously trials are continuing with both types of donors. But there has been a lot of debate about living donation and deceased donation of uteruses from a legal and ethical perspective. So there are questions around consent to donation. So for living donors who know the recipients, for example, a mother donating to a daughter, there are concerns around familial pressure to donate or possible regret, particularly if the transplant is unsuccessful. So the consent process is very important. There's also questions with deceased donation around whether a family member could or should be able to consent on the behalf of a deceased relative to the donation of their uterus. And that's particularly important when we're looking at opt-out systems like we have in England and Wales. The uterus is not automatically donated under our current legislation, but it is something that actually might be possible with the consent of a family member. So consent is very important. The risks involved obviously is something that shouldn't be underestimated, and the consent process has obviously a legal and ethical dimension to it. So I think I've taken up my time there, Sarah. So it's just to say thank you very much, everyone, for listening. And obviously I would encourage you to, if you are interested in these issues in more detail, hopefully that you'll be able to access the book as well.
And it's not a question, but it's just it's from Nikki Weimar, who's saying she doesn't have a question. I just want to say thank you to Mats for his incredible work. I'm a living uterus donor in the US, and Dr. Johannesson, who was on your team in Sweden, was one of my surgeons here. So this is sort of shows what a real international collaboration this is, and how the sort of work has spread globally. But I think that the it's sort of come across in the presentations. So the question I'm going to ask then is from Hannah Flynn, who says, you mention, and I think this is for Richard and Isabel, you mentioned that one donor was discovered to be unsuitable after death. So I think we're talking about a deceased donor, your deceased donor. What, if any, screening can you do to ensure that this doesn't happen in future? So if one or other of you would like to elaborate on that, I don't know who wants to go first. Perhaps Richard or Isabel.
You happy, Isabel? I'll go first.
Well,
Yeah. So I mean, this was a multi. It was a situation of a multi-organ retrieval. And so the uterus was one of other organs that were being retrieved, and it looked to be absolutely perfect until we got back to Oxford for the back table work. And as Mats said in his presentation, there was a line which showed that if you were doing deceased retrieval, there's a very, very short time to make the assessment. So that our assessments in that setting cannot possibly involve looking at blood flow within the uterus, except on an ultrasound scan, just with the Doppler flow. It's not nearly as detailed as a living donor. And it's one of those potential risks when our pool of donors through NHSBT is running between 18 and menopause. And of course, the older people are, the more likely they are to have atherosclerotic disease. So nobody came to any harm from the fact that we did not transplant. In fact, it's a very important part of the decision making that we don't implant a uterus which is not going to do what it's meant to do, which is carry a baby. Isabel, do you want to add to that?
I think, I mean, we do a lot of assessment in donors before we retrieve any other organ, and this is not unusual. Very often, in the context of cardiac retrieval, for instance, or heart transplant, we may find that there is some small vessel disease, or in any other organs. Until the organ is properly assessed, we cannot tell for certain whether it can be transplanted. So it's not unusual, really.
And I think while we're on the sort of subject of deceased and living donors, Rafi Wright has asked, is there a difference between deceased and living donors? Is there, and I presume they mean a difference in protocol, etc. So I don't know who wants to go first on that.
Just briefly mention, obviously, in a living donor, you have to limit the length of vessels that you remove, because they affect the living donor. You don't want to put that patient at any risk. With a deceased donor, you're not limited by that, and then you can extend, have a much longer length of vessel. However, technically, it remains a more difficult and challenging operation. But it might be that we are at this stage, still developing techniques, still learning how to do things, and perfecting what we do. And from the point of view, what is the benefit of one or the other? Not everybody has a mother that is suitable, sister that is suitable as a donor. So the disease program gives us, in theory, a huge potential for donor pool that most patients, or many patients, don't have. So I don't think it's one, or I think it's just part of the same process.
And someone else, someone has wanted to be anonymous, has said, Dr. Richard, in your opinion, which is a better program, living donor or deceased? But do you want to
Oh,
sort of...
absolutely wouldn't differentiate between the two. I think it's so when people come to see us in clinic, we discuss adoption, we discuss surrogacy, and we discuss transplant, and we discuss living versus deceased. And if they say that they may have a donor, then we arrange the next appointment where they'll bring the donor. And I have to say that, what happens in that clinic is that many people, and it starts in Charing Cross, and then they go to Isabel's clinic in Oxford, and many people, of course, decide when they understand the full kind of panoply of the procedure that they don't want to proceed with this. Others may start thinking that they're coming with a living donor, but the living donor mother or sister hears the whole story and said, this isn't for me, or we find the living donor isn't a suitable match. So this is it's a fluid situation where people either lots of people say this isn't for me, and they say I'm going down the surrogacy route or I'm going down the adoption route. Those that think it's right for them, it changes, and so we have an ability to be flexible here. And I don't think it's a case of it's not in a direct answer to the question. Sorry, it's not a case of one's better than the other. They've both got pros and cons.
Mats, did you want to come in on this one? That sort of this distinction between dead and living donors. Oh, you're still on mute.
So my experience of deceased donor, we have actually done 42 transplants in Sweden and around the world. I've only done one deceased donor, and of course it's surgically a lot easier. And as Isabel says, it's also easier in the recipient because you get bigger vessels. But the disadvantage is, of course, that you don't have so much knowledge about the uterus as you have on a living donor. And it's another thing with is that you can plan the surgery in a living donor procedures. In a deceased donor, you may not have the optimal surgical team on place to do the procedure.
Great, thank you for that one. I think unless anyone's got anything else to add, I'll move on to the next question. So someone's asked, have you seen any psychological effects, especially experienced by MRKH patients? Are there any research studies on the psychological effects following a uterus transplant? Many individuals with MRKH often use suppression as a coping strategy following their diagnosis. Moving forward with uterus transplant could potentially make past trauma resurface. So does anyone know?
Well, Matt should answer that.
Matt's excellent.
Yes,
Absolutely.
yes. So we have published extensively, especially on this special our psychologist, Stina Järvholm, both with questionnaires and also with quality data. And the main thing is that the patients, MRK patients, which have been in majority, they are very happy that they did a procedure. Even if they didn't succeed to get a child, they're happy that they actually tried. We know that the body image is, of course, positive in having a uterus, just feeling like a normal woman. It has also been beneficial for this sexology aspects and so on. So mostly positive, I would say. And a lot of them have expressed, well, now they are in the same boat as other infertile couples. They would have the chance, at least, to have a pregnancy. So it is good for them. But we have to realize also that in the first trials in every country, we get a very selective population of recipients, the very strong and tough individuals who are willing to go into the unknown. It may be different later on when we get also recipients with psychological or psychiatric comorbidities and so on.
Yes, I think that's a really important point, isn't it? That, to to be in something, a pioneering surgical program, it does take a certain type of individual. So yes, it would be interesting to see how that develops, but really interesting to hear that work has been done assessing people. It's so important. So then we have a question from Jessica Hamzelu, and I think it's been repeated by somebody else. Somebody else has asked a very similar question. I think they were called Linda from memory. And they asked, will it be feasible to perform uterus transplants in trans women?
So, Mats, do you want me to start? And yeah, I mean, so what we've all described this evening is a thing called Moore's surgical criteria, which is where you innovate in surgery. And Matt's had a beautiful slide about that, where you go from animal and then we move on. And I had a similar slide to surveys, to cadaveric human work, to human work. And I personally think that the transgender community have been given an impression which is raising an element of false hope for responsible transplantation in the near future. Because we've been at Moore's criteria for cisgender women for 20 years. And we have done one thing, which was that we wanted to find out whether there was a desire within the transgender community for uterine transplant. And that was Ben Jones' idea, and he ran that project, which was a survey, which was a very powerful survey, and it showed that there is a desire within the transgender community for uterine transplantation. The issue which is potentially afflicting this is that if people come to us with a neo-vagina, an artificially created vagina, who are cisgender women, they're not eligible for our program because those women have a very high rate of miscarriage because they've got the wrong microbiome within the vagina. And so there's a huge amount of research requires to be done before this could be translated into the transgender community. And I know Mats has published on that, so I'll hand over to you, Mats.
Yeah, I fully agree, Richard, and that is what I have stated in some articles, that I think this may be realistic in the future, but we have to do a lot of research, and that has to involve the same systematic research we did in the female, but in several animal species. But because it may not be as simple as we think, and we should not take the risk. And I know that there are some activities that have been published, a couple of papers in some animals on transplantation of uterus in the males. No pregnancies yet, mostly to look at the early effects.
Does anyone else want to come in on that? Do you want to come in on about the sort of ethical issues around, because you touched on the ethical issues around this and the legal issues, Natasha?
Yeah, so it's something that has been discussed and debated within law and ethics. But I think I'd just like to point out that notwithstanding the medical issues, that there is a lot to be discussed from the legal and ethical side. So from the UK perspective anyway, we've got so much legislation that would need to be kind of taken into account to determine if it could be legally performed. So we've got human rights issues, equality legislation, our assisted reproduction legislation as well would need to be looked at as to whether that would allow for the transfer of an embryo into a transgender woman. But I think it's also a question around what the purpose of a uterus transplantation is as well. So whether it is about providing someone with the opportunity to gestate and to become a parent, or whether it's about gender realignment as well. It is a scarce resource. So again, it comes to questions of ethical allocation as well. So it's got its medical side to obviously be determined, but the law and the ethics it's not a simple answer. Let's put it that way.
And I'm going to ask a question of my own now. I don't think this is in the Q&A box, but sort of thinking about the funding of uterine transplants and how you've done this through a charity. I don't know what work Richard and Isabel have been doing in the UK to see if and when this could be available on the NHS. Is this a likely possibility at any time in the near future? Do we know? I don't know who wants to go
Isabel,
first. Richard
do you want to take that one first, or do you want me
or
to?
Isabel?
I don't mind. Go ahead. You go ahead. Yeah.
So, I mean, our earnest desire is that this does become something which is available via the health service. We originally, in fact, back in 2015, had sign off from the Secretary of State for Health that when we finished our in situ study, that there was prospect for this being funded, and similarly, there are thoughts around the living donor program. I can tell you, as the chairman of Womb Transplant UK charity, it is certainly our aim to pay for the first 15 cases, and we fully expect to be able to potentially fund more cases beyond that, because there was always a problem for our charity, which was, we hadn't done it for ages. But with that, we've now got that credibility, and our charity has flourished on the back of that. So I think it's a case of watch this space. It's not going to happen too quickly, but I would sincerely hope that people, the NHS, would see their way to funding these procedures in the future. And certainly, if people sat down with the women who are suffering from this condition, they might feel more inclined to say yes to that. That would be my answer.
And Mats, what's the
Yeah.
situation with funding in Sweden?
Yes, so I just, in a European perspective, it is a approved procedure clinically within the health system in Germany since 2021. It's on the way in Czech Republic, and it's also on the way in Sweden. So I think from 2025 we'll do fully publicly funded transplantation procedures in Sweden. So we just had a meeting with the hospital board today and got an okay for that. And that means that also for citizens within the EU, if they cannot get the treatment in their country, they have the right to go to Sweden or Germany or Czech Republic to get it done. And the home country will have to pay for it.
That's great news for our
But
European.
you are Brexit.
Yes, another something we certainly didn't anticipate with as a result of Brexit, shall we say. Moving swiftly on, or we get onto the subject of Brexit. So there's a cheeky question from someone who's anonymous that you may not be able to answer. Isabel and Richard, is there any update on the UK patient that you're allowed to share post their transplant? I.e., they want to know, is there a pregnancy?
Yeah,
I can't imagine there's going to be any breaking news about pregnancies on this call.
really sorry, we're not in a position to answer that sort of question until we make publications in future, and we've got to be incredibly careful about our patients' confidentiality. So I'm sorry, I can't answer that question.
I've never been actually more pleased that a question hasn't been able to be answered in some ways, because that is so important. And I have seen a dreadful case where the sort of patient was splashed around, and it's just it's not great.
No.
Okay. So then Victoria Adkins has asked, this is for everyone, do you think the advancement or availability of uterus transplants is or will be impacted at all by the ongoing development towards artificial placentas? I don't know whether any you guys know much about that. Mats, do you want to go first?
No, I think, the problem is not artificial placentas, because, that's fetal tissue. The problem is, of course, artificial uteri, and that is, we and others are working on what we call bioengineered uteri. That is actually to create uteri from stem cells. I think that may be a future. Because for this group of patients, of course, the placenta is not a problem. It's a uterus. The placenta is possibly a very, very complex organ, and I think it will be very difficult to do artificial placenta.
So I completely agree with Mats. I mean, we've done some incredibly preliminary work on warm perfusion. I mean, this is it's the stem cell stuff is a far more positive approach. I've no doubt about that. And we started. We're not in the same ballpark as you with that, Mats, but we've done stem cell stuff around endometrium, which we've got some really positive results, which may benefit women with Asherman's syndrome. So we've got people on our waiting lists who have a uterus, but the uterus doesn't have a lining. And at the moment, an option is, of course, to potentially do a uterus transplant. But with stem cell therapy, it's possible one could create a new endometrium, and that's got prospects. That's a small subset of the whole group.
It's fascinating. I'm going to sort of take us back to the donor again. As a few people have asked various questions about the donor. So Esperanza has asked, can a sister donate her uterus? And somebody else has asked, who other than family members and close friends can donate, and what are the requirements for living donors? How do you select them, and what screening do you apply? So I don't know who wants to go first on that. First, we'll go to Mats.
I can say we have done two sisters, actually three sisters, older sisters having 3 to 4 children, and 2 of those have been successful with. But of course, they have to clearly have determined that you're not going to have any more children and so on. So I recommend the age would be above 40, but I think our youngest was 37. So that is, of course, a good. The advantage with the sister is that she's younger than the mother, and the arteries are better. We used to have this age limit of donor to be 62, but now we decreased that towards 55 because we know that the older uterus gets the worse the arteries get in the diameter. So that, then of course it's the usual inclusion criteria that they should be healthy and should have a good uterus and no serious comorbidity and so on. We can accept family relatives, but also distant relatives. Like we had one, the father of the husband's cousin or something like that. So it doesn't have to be close, or they can be long-term family friends, but they have to prove that they have had long-term relationship. And of course, we want to avoid that there are any money involved in this donation process.
And is that the same criteria that you have in the UK?
No, we're sitting at the moment, it's either mother, daughter, or sister, sister. But Isabel, I don't know if you want to comment.
I think we want some close relationships, especially at the beginning. We don't have a great experience like you, Matt. And they have to, like with any living donor, they need to prove a very close friendship or kingness. That's part of what the independent assessor goes through. And this is the same with any other living donor transplant kidneys or living donor transplants. But there is absolutely no reason why, as Matt is suggesting, that we should not explore other types of donors, living donors. And currently, as I was suggesting before, loads of women had approached us, and I'm sure at some point we will look into that. And by law, Natasha, as you know, the Human Tissue Act would allow donation between strangers, like a non-direct donation. So by law, it would not be prohibited. And in the States, for instance, that's one of the main sources of donors are just volunteers, people that really want to give that hope and that opportunity to other women.
Yes, because someone's
watch
asked.
The space is going to happen, and it will happen here.
Yes, because Derek Manus has asked several questions, but one of his was about the potential for non-directed altruistic donation in the UK.
Certainly by law, and we've spoken with the Human Tissue Authority, that the law is clear on that.
And Natasha, did you want to come in at all about the the sort of to tease out, because you didn't have much time in your presentation, the sort of some of the ethical issues among those sort of family donations, or whether it would be better
Yeah, I mean,
if the medics would.
one of the concerns that that I mentioned and that has been written about is that actually there is some concern that if you're donating within the family, is to make sure that consent is truly free consent, so that there's not pressure to donate from, say, from a mother to a daughter. I'm not suggesting that within the UK team that's obviously a process that's a concern, but it's something from an ethical perspective, is that that there is concern about pressure within families to donate. So there is the potential, actually, if you are using either deceased donors or non-directed living donors, that actually that concern would be removed, essentially. So I can see why Isabel mentioned one of the teams in the US is doing this non-directed living donation, that actually that helps to appease some of the ethical concerns around pressure and around consent.
It's interesting because non-direct donation didn't happen until 2001, 2, something like that. The first time I heard about it, it was at a conference in the States. And I thought, oh, well, these Americans, they come up with some creative ideas. And now it's common practice. We do it quite often. And there's incredibly generous people out there. So the ideas that we have, the concerns that we have now, I'm sure soon will change. And these arguments that we have, as we get used to it and as we think it through, I'm sure the argument will move on. But if you can imagine, if it's your own family, your own mother, your own sister, of course they will want to help you. And if they are well consented, well informed, and as long as they can justify all those arguments to people that are totally independent of us, those independent assessors, nothing, I mean, very little goes through them, goes past them, then we will be satisfied.
And I think as well, if I might chip in again, Sarah, is that there needs to be a debate around the donation of uteruses more generally, because as I said, within England and Wales, we have this donation system whereby you donate effectively automatically upon death, but uteruses are not included within those organs. So it's something that actually, if we want to potentially increase the supply of uteri from deceased donors, and we want to actually include those as being an organ that's automatically donated, is that we need to be having those conversations and about educating the public about the possibility of that. But it reminds me a little bit about some of the debates that were around donating hearts originally, about kind of the value that is put on hearts and put on uteruses, that this is something that we need to obviously be respectful of people's opinions and views, but it's a debate that we need to have, and about educating about the work that can be done. I mean, there's still uterus transplants that we're 10 years on from the first one. As Isabel said, that it's a tiny number of transplants that have happened in relation to other organ transplants. So many people don't know that this work is ongoing. So I don't think we could change our laws, for example, in the next year, for example, to include uteruses automatically upon death, but it's something that could be done potentially in the future, but through educating the public that this work is ongoing.
Sounds like
Absolutely.
a nice.
I think that there's no, sorry to chip in, Sarah, but there is no plans or change in law, and change in laws takes so long. I mean, that you don't even want to go into that one. But no, there's no deemed consent for non-life-saving organs. So there's absolutely no deemed consent, for instance, for a hand or a face transplant. So that's very intense and meticulous work that the senior nurses in organ donation would have to do with the families, and freely to obviously to say no for families that they don't agree with this.
Yeah, it's that sort of sweet, again, it's not going to be for everybody, this is it. It's going to be what values people attribute to different parts of their body. and perhaps not what they would attribute to it, but actually what the people they leave behind decide if they've not specified themselves. So yeah, big education piece probably around that is what's needed. A nice little campaign for someone. And talking of campaigns, we have Charlotte Bishop, who's the director of the UK charity MRKH Connect, and she said they get a lot of questions about the availability of uterus transplants, which is perhaps no surprise. She said, we understand it's in trial, but what is the realistic time frame, if there is one yet, of when this will be out of trial? It also, of course, links to limited fertility funding options for anyone requiring fertility treatment who would usually require a surrogate, e.g. in the case of MRKH and surrogacy, something we're also fighting for under our collaborative campaign, Fight for Surrogacy. Will fertility treatment for those who require uterus transplants also be, and she put in scare quotes, easier? So I think perhaps for Isabel and Richard, one of you two to go first on that, about when it might possibly be out of trial. You've done one, you've got 14 to go. Is that right, if I've understood correctly?
So what I would say is that I would expect a timeline of something like 2 years to have finished the trial aspects of what we're up to. And that ties in with what we're proposing to, proposals to put into NHS for NHS funding, etc. And there's a subsidiary. I'm just looking at the question. Of course, links to limited fertility funding. Agreed. Fight for surrogacy. So you see, to me, I mean, it comes back to what we were saying before, which is that people come into the clinic and we openly talk about all the different options, and what's right for one person's not right for another. And so the push shouldn't be, oh yeah, it's all about uterine transplant, not about surrogacy, or it's all about surrogacy and not about uterine transplant. These are all potential options into the future. And will fertility treatment for those who require uterine transplants also be easier? Well, you see, that's a fascinating question, because that depends how the whole thing develops. I mean, we've certainly noticed that if people are coming for a uterine transplant, then depending where they live, they may find it easier to get IVF, because they won't get IVF for surrogacy, but they might get IVF if they're going to get a new uterus. And that varies area by area. So this is an absolute Pandora's box, and difficult to know exactly where it will go. I don't know if Isabel, do you want to comment on that?
Well, I think it's only worth mentioning that currently, yes, the charity pays for the transplant and the aftercare, pre and post, but we can't pay for for the transplant, but we can all pay for the IVF. So that is a huge cost that women are incurring, and whether that's going to change in the future, I don't know, but I suspect it would be like any funding for fertility at some units. In some areas in the country, you have one cycle pay for the NHS. In other areas, your health authority will pay 2 or 3 cycles. So that varies a lot. But what I think it would be worth stressing is that women with this type of infertility have the same rights that other women with different types of infertility. So I don't see why they shouldn't have their IVF paid for if they're planning to have a uterus transplant. So I think that would be quite unfair to be denied that.
Natasha, do you want to comment on this point before I move on about the sort of inequality of access to treatment?
Just to say, well, I think just to agree with what's been said already, is that it's such a disparity across the country that I think that it's who knows really what would happen in the future. I mean, it wouldn't make sense from my perspective to do the uterus transplant without also being able to access IVF, obviously, at the moment. But as to whether it should be easier for someone who's having a uterus transplant to access IVF than others, I think that's a whole another debate, essentially. But as state-funded IVF is so difficult to access anyway, I think it's going to be a problem whether you're a uterus transplant recipient or not.
Yeah, it's something that PET has done
Yeah.
does a regular work on, and we have a fertility policy tracker for England on our website to enable people to find their ICB and see what's available. We update it monthly, and we couldn't say that it's going. We kickstarted that in July, and I can't say it's a positive trend in the way things are going. It's difficult to know how it will end up. So. We've not had any questions for Eleanor, but I hope, Eleanor, that you have read many of the really positive comments in the Q&A box about your presentation, and also in the chat. So just thanking you so much for sharing your personal story. No question, just isn't Eleanor fab? I think that sort of says it all from Tracy Sainsbury. So yes, so thank you so much, and I've been trying to think of a question for you, and I can't really think of one that's not terribly that's not quite appropriate. So I will move on. So I think people are interested to know about again, it's Derek Manus actually. He's said, who promotes the alternatives prior to considering a uterus transplant? Are they independent to the transplant team when you're talking about those? So I guess that's a question perhaps for Richard first, and then perhaps Natasha can come on about the sort of the nitty-gritty about it from a sort of ethic legal point of view.
Okay, so the vast majority of people who are coming to us have got MRKH, and they've come from the various centres within the country who look after those women. And so there's a big sifting out before people get to us. And I certainly can absolutely put my hand on my heart and say I do not have any bias towards promoting uterine transplant against other options at all. Right? In fact, I've spent many years before we got going bringing women to clinic who were absolutely not going to ever be able to have a transplant, so that they would know that they could get closure. And so, no, so the sifting process it's the referral process in the first instance. Then they come to us, where we absolutely freely and openly discuss options with them. And I can genuinely say, I believe without bias. Then they go to Oxford, and often when they get to Oxford, they hear a slightly different take on the whole thing, and that will put them off as well. And then, of course, if it's a living donor, there's the Human Tissue Authority independent assessment that goes on. So, but so that's the process. Are we bringing in somebody else? So I suppose I would say that, Ben Jones is our IVF specialist, Prof. Tum, and we will regularly say to people, go to discuss surrogacy there, and we point people to the Bourne Hall site and all that stuff. So it's a kind of there's different aspects to the team. I don't know if that answers Derek's question or not, but it's Natasha. Do you want to comment?
Yeah, I was just thinking about how essentially it would almost be part of the consent process, in the sense that you need to know about alternatives to the treatment that's being proposed. So in the sense that obviously Richard said that the people who they're seeing that actually have often done a lot of research themselves anyway about the best options for them and what might be feasible. But obviously they are also within the Womb Transplant UK team having those conversations with potential recipients. So it's about knowing what your options are and what the alternatives to treatment are, so that you can make the best informed decision that you can in the situation that you're in. And obviously for something like this, it's very much a personal choice, in the sense that you would have your own personal morals. You might have religious views that might influence whether you think that surrogacy is or is not an option for you, for example. So it's, as we know, reproduction and the ability to or not reproduce is something that is very personal to you. And from the ethical and the legal perspective, it's about making sure that you've got as much information as you need in order to make those decisions.
Can I
Great.
say, I
Yes, Isabel.
totally agree with what is being said. I mean, I had a clinic today. I saw two women, both of whom had done a huge amount of research. And they had genuinely considered very deeply what their options were for them as women, for them as a couple, and for the extended family. And I have, and Derek, you can be reassured that I've had at least 3 women that, after hearing me talk about cancers and infections and potential death, because this is a possibility, it's not without risks, they have said, actually, we thought about it and we'd rather go down the surrogacy route. And absolutely wonderful. We are giving choices to women for what's best for them and their family. And there have been some people that have been scared off after this, and afterwards they came back to the program. So I'm sure that there's no perfect program anywhere in the world, but I think that our processes are stringent and as robust as we can make them. And that's part of the thing, is that we thought initially that we needed to make the whole process very easy to women. We wanted young women they're very healthy, so they don't need multiple appointments, and we just get them on the list and that's done. That was totally the wrong approach. What we do now, we see them multiple times. They need a lot of reassurance. They need to talk. They need to understand what they're getting themselves into. So 1-2 visits is not good enough. They need to be committed and understand what they take on.
Great, thank you very much for that. We're sort of getting towards the end of the event now. A couple of people have asked sort of technical medical questions, like, if one of your kidneys is in your pelvis, would a uterine transplant be possible? I don't know. That's an easy yes or no answer.
That is currently is not. It's an exclusion criteria in our program because the anatomy is very complex. But it might be, again, with more knowledge, more experience. It might not be in the future.
Another one is, could my mum donate her uterus to me even though she had breast cancer many years ago?
I've read that. I mean, breast cancer is one of those cancers that in a way is difficult to know whether you've ever been cured from it. And I think that will need a huge discussion. Even for deceased donors, yes, we do accept deceased donors after breast cancer, but it's always consider a higher risk of recurrence, especially once that you have immunosuppression. So a tricky one, that one.
Okay. And then the other one is from Chloe, who says, I only have one lung, the second was removed at a young age. Would I be suitable?
That will need a lot of assessment from the anesthetic point of view and the lung function point of view. And if the anaesthetists are happy, there's no reason why she wouldn't be a candidate, but it needs assessment.
And then Anna has a question. Have there been any cases where the medication taken by the mother during gestation has negatively affected the fetus or the baby? Can anything be revealed in the future in this respect? So
the drugs that we give, the drugs that patients have been used for decades on other transplants, not uterus transplants alone. So we do modify our immunosuppression protocol 3 months after the embryo transfer to a drug, one of the drugs that is not teratogenic, it doesn't affect the fetus. So we do everything we can to reduce that risk. But of course, this is high risk pregnancy, and which you may come into. As per se, the drugs being teratogenic or affecting the embryo, no, but of course they do affect the woman in many other ways. So you can have a higher risk of preeclampsia, as Mats was saying, and there's increased diabetes. It might affect your renal function because of the drugs that we give. So it's not without risks, of course.
Okay, and then we have I think we've already covered this question because someone else asked it, but Linda seems to think it's not been answered, and she's posted quite a lot in the Q&A. So she says, is this an option for men who identify as women to get a uterus transplant? So I think we have covered that already, haven't we?
We have
Mats?
covered that within
Yes.
the transgender setting.
Yes,
Yeah,
exactly. Okay, right. So I hope you caught it, Linda, when they did answer that, because I thought I'd remembered that would all happen.
Just say, sorry, Sarah, I forgot to mention, to date, of all the babies that have been born in the world, none of them have been born with any malformation. They are all fit and healthy children, except one that had maybe autism, but that's within the expected incidence for any other child born.
Great. I'm going to ask one more question. Would you accept a donor with a history of endometriosis after 2 full-term births?
So, will I take that one as well? So the answer to that, it would depend on how severe the endometriosis was. So if there was very severe endometriosis with bowel infiltration and that kind of thing, that would make life extremely tricky. But if there was mild endometriosis, that would not be a preclusion. So that's again, this is one of the great advantages of the living donor setup, where you can make full assessment of people in advance, and you've got ability to do MRIs and angiograms and all the rest of it.